You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 9th, 2024. Our topic today is Joint Task Force on Practice Parameters discussing atopic dermatitis. Our presenter is Dr. Derek Chu, a clinician scientist and assistant professor of allergy and clinical immunology at McMaster University in Hamilton, Ontario, Canada.
For atopic dermatitis, with a particular focus on the recent guidelines that we just released through the Joint Task Force. And I'll try to add a few little tidbits here and there. Happy to take any questions after my emails there if you'd like. Okay, I would be remiss to say that, that this was not a multidisciplinary, very large group effort. We had a massive guideline panel along with many patient partners. In the bottom here, we tried to also be very mindful about equity, diversity, inclusiveness, balancing gender, ethnicity, seniority in academia, community and academic practice, specialties involved, as well as geography. We also had the engagement with many patient groups, including NEA, GPER, and Allergy Asthma Network. So very thankful to everyone that contributed to developing these guidelines. In the evidence and allergy group, we supported many of the systematic reviews and evidence syntheses to inform the guidelines, as well as facilitated the development of the guidelines. And so there's a very large group of individuals, including international collaborators, that have helped make this happen. I have no direct financial conflicts of interest. I do help develop a process of translating evidence to recommendations and assessing the credibility of a body of evidence called GRADE. I chair the evidence and allergy group. My funding is federal funding or through the AAAAI and the hospital or our provincial ministry. The views today are my own, and I'll be sharing with you on the Joint Task Force slide deck, though. The objectives are to apply the updated recommendations, incorporate new and systematically praised evidence, and distinguish trustworthy guideline development and evidence-based principles. So atopic dermatitis is a massive burden. It affects 10 to 15% of children. There are some estimates up to 20% and about 7 to 10% of adults. It has a negative impact on quality of life, and it's a chronic relapsing itch and skin inflammation and skin pain syndrome. It causes major changes to sleep and quality of life for both the patient as well as the family, and has a number of comorbidities and complications, such as those that we're very familiar with, the atopic comorbidities, asthma, allergic rhinitis, food allergies, and even urticaria. But there are non-allergic comorbidities and complications, such as depression, anxiety, infectious complications that we're very familiar with, such as herpes infection, such as molluscum, such as tinea, and of course our bacterial, such as staph infections or impetigo. Contact dermatitis is increased, particularly with scented moisturizers, for example, but also less commonly to topical steroids themselves. And then with repeated corticosteroid exposure, both systemic as well as topical, there's concern about osteoporosis and fractures long term, as well as potential cardiovascular implications. It is a complex disease from a pathophysiology standpoint. I will not go into great detail about the immunology, other than it is thought to be a combination of hair dysfunction, which does have a genetic basis for many individuals, but also environmental factors, microbes, and disruptions in innate and adaptive immunity. From a diagnostic standpoint, the main, most dominant diagnostic criteria are the Hannafin-Brashka criteria, which are very extensive, as you can see here on the left-hand side. A modified version of this that was thought to be tried to distill the most essential elements is presented on the right-hand side, called the UK Working Group Party 1994 criteria. This is an itchy skin condition that has at least 3 of the correct location being involved, such as skin creases or intertriginous areas or flexural areas. Second, the correct visible signs, such as flexural eczematous dermatitis or face involvement in younger individuals, and then a personal or family history of allergic disease, and then a history of generalized xerosis and early onset disease. Now, this is the general criteria that is often useful for definitions, but you do have to keep your mind open about potential differential diagnoses, particularly the rare inborn errors of immunity syndromes that can be part of, they can present with atopic dermatitis, such as DOC8, STAT3, hyper IgE syndrome, Wiskott-Aldrich, and others that, particularly for us, we will be, as allergists and clinical immunologists, have to be especially attuned to. Now, the morphology can change over time and relapse and remit, and this is one from the Lancet that can be that is quite striking. You can see it ranges from normal skin at the moment to non-lesional but active skin, acute eczematous dermatitis, subacute eczematous dermatitis, and chronic. Noting again that eczema by itself, which is our common language, may actually mean on a clinical basis many different forms of, from a pathophysiology standpoint, what it actually, the cause of that dermatitis is. We are today focusing primarily on atopic dermatitis, but you have to keep your mind open about all the others, such as allergic contact dermatitis, irritant dermatitis, such as infectious, such as radiation, and so on and so forth. The complications, as you can see, that would progress beyond chronic dermatitis on the top right-hand side here include those such as lichen simplex chronicus or prurigo nodularis. There may be some associated signs, although these are not definitive, such as palmar hyperlinearity in the bottom left here, Denny Morgan lines, or Birthgos signs. And in addition, you may notice more follicular accentuation on certain areas that may either be confused with or associated with atopic dermatitis, such as keratosis pilaris. Now, this is some of the distributions that can be seen that changes with age. In the top, you can see that infants may have a more face involvement that then migrates to becoming more flexural involvement, and then in adults, there can be quite a bit of neck and hand involvement. And again, hand dermatitis may have a completely separate differential diagnosis by itself, and be, especially in older adults, that you may need to have specific considerations for. But I'll be talking today in general about atopic dermatitis. The other thing to note is the variation in skin color that I'll note here on the right-hand side of the slide, and that in particular, when we use terms such as erythema, this is primarily in its most common form or most literal form, meaning red. But in patients with skin color, that might be harder to appreciate. In actuality, you may see more purplish hues or more subtle signs that you have to inspect more for, but ultimately still reflect an increase in cutaneous blood flow and inflammation because of underlying disease. And so you should be mindful to about this potential gap, which is often missed. Now, how do we classify atopic dermatitis or measure it? A very common form is one example here called the POEM, or patient-oriented eczema measure. This asks many features to recall for the patient that they will self-fill out themselves, and can be used in advance of clinic so that when you see them, that you can actually understand what their disease activity over the past week or 4 weeks is. Now, there are other common measures that we use. Often these will be used for insurance purposes in addition to what are very commonly used in clinical trials or research studies. For clinician-reported atopic dermatitis severity, you can see here that can include EASI. Another one is SCORAD, which has both an objective component that the clinician will score, as well as patient-reported components of itch and sleep disturbance. There's the POEM that is mentioned, but there's also others, such as a visual analog scale, in other words, a 0 to 10 scale, or a numeric rating scale, again, a 0 to 10 scale, that the patient may be able to fill out to describe how bad their itch is on average or at peak in the past 24 hours, for instance, for itch and sleep disturbance. and there is a quality of life questionnaire. Many of these you'll have to fill out for specific insurance purposes going forward. But very importantly, as I've highlighted here on the bottom, that there are strata that are known for classifying a current state in front of you as mild, moderate, or severe should not be rigidly interpreted. These are continuums of severity, and that as a consequence, reported strata will vary slightly across studies. There are calculators online or apps that you can use to use any one of these and facilitate your grading. And in addition, there are even apps that are being promoted among patients to self-report an EASI or self-report a SCORAD, though there are some limitations to these approaches. So what's different with atopic dermatitis guidelines? We use multidisciplinary panelist engagement. We use a rigorous guideline development process. We use patients and focus on them from beginning to end, and then we translate those to actual recommendations. I may not be able to get through all the recommendations today, and so there might be some slides at the end that will go a bit faster on, but I do encourage you to look at the bottom right here to the guideline full reference in animals allergy, as well as the allergy parameters to look in greater detail. There are infographics available. There are also other additional knowledge translation pieces that we published, such as the most recent one in JAMA Pediatrics. So the guideline approach incorporates understanding the benefits of the magnitude of benefits and harms, certainty or quality of the evidence, patient values and preferences, and then considerations such as feasibility, adaptability, equity, and resource use to determine the recommendations. We also considered comorbidity. None of these, very importantly, is a mandate of care. You do have to tailor them to the patient in front of you. When we did a systematic review of values and preferences, we included over 19,000 patients in 62 studies. Patients prefer treatments that have a low impact on their quality of life and activities of daily living that are easy to use, that relieve that burning and itching. They do have concerns about side effects and adverse effects. They prefer having physician reassurance and clear instructions on how to use. They prefer step-up therapy, ideally with addressing those non-pharmacologic therapies to begin with, and then they prefer to use topical steroids for the minimum amount of time as possible. In the GRADE approach, we then went through all the different categorizations with randomized trials for interventions starting at high certainty and non-randomized studies starting at low certainty, them being rated down for other limitations such as risk of bias, inconsistency among the body of the evidence, and ending up with high, moderate, low, or very low certainty. When we make a recommendation, strong recommendations show that they are very clearly outweigh the benefits, very clearly outweigh the risk, hassles, and costs, and conditional recommendations may be due to low certainty evidence or the upsides and downsides are closely balanced. Now, for strong recommendations, the implications are that almost all patients will have the same choice. Inform them, it could be a potential quality metric, and more research is less likely to change that recommendation. Whereas a conditional recommendation means more so this caution approach, that yellow light signal. That means ensure that the treatment reflects patient values and preferences. Might have to have those additional tailoring to the individual patient in front of you. The guideline has very clear instructions about key considerations to consider for each individual patient. And like I said before, guidelines are recommendations. They're not specific mandates, so it's not a blanket for all patients in front of you. So we address topical treatments, elimination diets, dilute bleach baths, allergen immunotherapy, and then systemic treatments. So before starting anything, the overarching good practice statement is that, number one, ensure you have the right diagnosis, no complicating diagnosis, as described earlier. Number two, provide education, for instance, about the disease and a written action plan. Many examples online. There's a ton of information when that first patient comes to you in clinic. They're going to take home about 10% of that. And so giving some additional written information can help facilitate and have close follow-up at the beginning. Third, address trigger avoidance, such as common irritants, ensuring fragrance-free moisturizers and so on. That proper medication is used and that it can be easily adhered to. And that lastly, encourage a bland moisturizer at least once a day, if not multiple times a day. There are some key handouts that can be here, such as what parents should know about atopic dermatitis in JAMA Pediatrics. It's a one-page handout, as well as the updated guidelines down there in JAMA Pediatrics as well. For topical treatments, we'll start with the calcineurin inhibitors. Are they safe and effective? There are three main ones: TAC 0.03, 0.1, as well as PIM 1%. They're approved for the ages shown here. They're often used off-label in younger ages. And same thing with pimecrolimus, approved age 2 years and older. In Canada, it's 3 months or older. So, very common concern was a black box warning for topical calcium inhibitors. This was primarily because of a theoretical cancer risk based off of animal data, systemic usage, including those for organ transplant, and case reports from uncontrolled adverse event surveillance studies that said the cancer could occur in as soon as 2 weeks after exposure. So we did a systematic review and meta-analysis published in Lancet Child and Adolescent Health. We included data over 3.4 million participants in 110 studies with follow-up up to 150 months. And shown here in the bottom is the summary of the effect estimates showing no credible increase in, no likely credible increase in cancer when used in a normal routine fashion. That's to say, not using wet wrap therapies, which has not been studied, or slathering all over the body at very high doses multiple times a day. We did many different subgroup and sensitivity analyses: age, sex, duration, severity, study design, publication tests. All these, the findings were consistent. And in other words, monitoring the evidence shows no increase in cancer among those with typical usage localized areas 1 to twice daily. We also then did the first ever topical treatments network meta-analysis that compared all available topical treatments to each other, published in randomized trials. There was over 200 randomized trials, over 40,000 participants studied, peds and adults in it, and primarily mild to moderate severity. We assessed the key outcomes to gain and maintain control of eczema. We compared interventions used once daily to twice daily. We also classified the treatments according and harmonized them across all the different classification methods. And the key outcomes were disease activity, itch severity, sleep disturbance, quality of life, eczema flares, and harms or adverse events. There's a key summary findings table that I'll show you here in the next few slides. The left-hand side depicts how all the different evidence was connected to each other. Solid line denotes a randomized trial directly compared those two interventions. The size of the line denotes more randomized trials. The size of the circle, the solid circles there, denotes the size of the number of patients that were included. So here we'll start off with the calcineurin inhibitors. This is a summary findings table you can see that denotes each one of the different treatments as a row, and then each one of the outcomes as a column. The baseline is the baseline severity on the SCORAD scale, for instance, in that first column, and then so on and so forth for itch, sleep disturbance, quality of life, flares, and so on. If you look down in the middle here, the top calcineurin inhibitors, you can see PIM and tacrolimus are among a intermediate inferior category, in other words, a low potency for therapy, whereas the tacrolimus is in the intermediate superior effective, similar to groups 3 and 4 for effectiveness in terms of the comparing to topical corticosteroids. So for topical calcineurin inhibitors, are they safe and effective? We therefore made strong recommendations for adding topical steroids or topical calcineurin inhibitors for the treatment of atopic dermatitis. PIM, it has rankings similar to TCS 5 and 6. Intermediate between those two. TAC 103 is similar to 5. 0.1 is similar to 4. And few studies directly assessed different locations of the body, but those that did suggested similar treatment effects across all body sites. Key issues that TCIs are not associated with skin atrophy or other topical steroid adverse effects, and therefore they can be used for more sensitive areas such as face and folds. They can, however, cause adverse effects such as burning or stinging sensation, and therefore for severely active lesions, consider starting inflammation with a short course of topical steroids and then transitioning to topical calcineurin inhibitors. We also provide some other implementation tools that can be used to use these most effectively in the e-appendix that is associated with the guideline. So how about these other new medications such as ruxolitinib, crisaborole, antibiotics? The ruxolitinib, you can see here, had modest effects on severity and itch, and was similar, was crisaborole. The main difference is that crisaborole is licensed for being used all the way from infancy to adulthood, both drugs for mild to moderate disease activity. Although ruxolitinib has other considerations that I'll show to you on the next few slides. Antibiotics and prescription moisturizers, however, had little to no effect and were quite weak in their potency across outcomes and with low certainty, and therefore we made some slightly different recommendations. So, for in those that are refractory to these treatments, then there are the considerations for using other interventions, such as wet wrap therapy. In those that have localized lesions only, we made a conditional recommendation in favor of using a time and area limited trial of occlusive low to mid potency topical steroids because of their potential strong efficacy that is well detailed in the e-appendix about how the National Jewish Regimen uses this in the best way possible. In contrast, topical antimicrobials, as shown before, had little to no effect, and so they really are overused right now. There's even combination medications with low potency topical steroids and antimicrobials, but really they had little to no effect, and they had some potential downsides about promoting contact dermatitis, for instance, as well as antimicrobial resistance. So when patients really do need an antibiotic for infected eczema, they may be less responsive. And so we made a conditional recommendation against this medication class. For wet wraps, please consider the time and education that's really needed to make sure that they're able to use this, and age may be one of those considerations. And then for proactive therapy, we'll talk about shortly, that's about maintaining disease activity, disease control. So the other topical agents were crisaborole. So in this, as you recall in the previous slides, was low potency for effectiveness among those with mild to moderate atopic dermatitis. And so we made a conditional recommendation in favor of this, particularly for patients that value non-corticosteroid treatment, or might place a higher value on this rather than larger or higher certainty benefits with TCS or TCIs. The big concern here is that these drugs can cause quite a bit of stinging and burning, so you may have to be careful on sensitive areas such as eyelids or folds. There may be other ways to reduce that, such as applying a moisturizer first, and then being able to apply the crisaborole a few minutes after. You may also be able to use this as a therapy intermittently to treat mild flares. Now, for the JAK inhibitors, this would apply to the oral JAK inhibitors, and they've also, unfortunately, been applied also to the topical JAK inhibitors, for which have a overall box warning about them, but serious infections, mortality, malignancy, major adverse cardiovascular events, and thrombosis. This is derived from adult patients with rheumatoid arthritis randomized to multi-year trial of an oral JAK inhibitor, tofacitinib, or a TNF-alpha inhibitor. And so there are concerns about its applicability to younger patients with atopic dermatitis exposed to different types of JAK inhibitors. But unfortunately, this is a rather robust trial otherwise, and so we're left with low certainty evidence if these potential harms are a class-wide effect, and that's why the FDA has put a box warning on. So with that, given the lack of robust long-term safety data yet, we made a conditional recommendation of using ruxolitinib as a first-line therapy for patients age 12 and old with mild to moderate atopic dermatitis. There are many other treatment options available. The other thing is that if you are going to use this treatment, because many patients may still value using this treatment over topical steroids, topical calcium, is that it's approved for short and non-continuous use. It should be used for those over 12 years of age without other contraindications such as being immunosuppressed, immunocompromised, that have no major risk factors for those adverse events, and for which it's going to be used in less than 20% body surface area. There's also nothing to say that it can't be used in combination of therapies, although it hasn't been studied robustly in randomized trials when used as such. So those factors that might favor use of this are the patients that have not responded to other topical therapies already, Again, keeping in mind that good practice statement about making sure you have the right diagnosis and so on, that prefer a non-steroid, and that may value these modest effects over its other uncertain association with serious side effects. We eagerly await long-term safety data. How about using medications once or twice a day? We made, in the network meta-analysis, we found that using once and twice a day really had minimal differences. There was a small difference in twice a day over once a day, a 3-point change on SCORAD, which is a scale of 0 to 103. In other words, 7% more will improve when using this twice a day. And so at the end of the day, even though you have a moderate or high potency topical treatment, such as TAC 0.01 or TCS class 4, what you might end up doing is, on average, recommending it once a day, but saying to patients that they have the flexibility to increase the frequency to twice a day if they need to clear a lesion faster, if they prefer to just use it twice a day because they have a better regimen that way, and the opportunity for shared decision making and patient empowerment. How about proactive or reactive therapy? So this is about that maintaining disease control. So once a lesion is cleared, how to maintain clearance of eczema. There, on this row here, you can see each comparison is against this bottom row, and the corresponding rows and columns, those cells, compare the corresponding treatments, TCS5 versus 3, TAC, PIM, and so on. And so using a low-potency steroid, TCS group 5 was thought to be the most effective possibility with very low certainty evidence of its superiority, but with there was also low certainty evidence that tacrolimus may be quite effective compared to TCS group 5. But overall, there was high certainty evidence that proactive therapy, these blue cells here on the bottom, all significantly reduce the chance of a future flare compared to purely using it on a reactionary basis. So we therefore made a strong recommendation to use proactive therapy with a topical calcineurin inhibitor or a mid-potency topical steroid in almost all patients with a relapsing course. That means when using this therapy, most studies clear the eczematous lesion, then treated for an additional 3 to 7 days after, and then applied about 2 consecutive days per week, such as weekends, to sites with that have recurrent lesions. You can, there are different permutations, such as 2 or 3 times a week, but it need not necessarily be continued daily therapy. The concept is to reduce overall corticosteroid exposure and is an opportunity to use those TCS or other therapies. There's some emerging data, but the use of crisaborole for this to maintain disease control. Now, how about elimination diets? This is a very common concern that patients come into clinic with, looking to see if their eczema is being worsened by ongoing exposure to food allergens or occult food allergens. Now, this is published in JACI in Practice, and I very much encourage you to read the full study, but the summary findings is presented here. Eczema severity, pruritus, sleeplessness, IG-mediated food allergy, nutrition, and all the randomized trial data, which was few, 10 RCTs, only 500 participants, suggested a very modest effect in improving eczema control, potentially patient unimportant. However, in contrast, in those that are young, the best available data comes from data such as LEAP that suggests that avoidance of food allergens increases significantly the chance of developing a food allergy to food that was avoided, including not only just the food allergy, but also anaphylaxis. There are other prominent data, especially from observational data, that suggest a concern for nutritional deficiencies with strict elimination diets. So how to reconcile this? We know that patients are often very interested and will come in with this concern, and that there's been a concern historically of clinicians dismissing the patient concern. So there is some credibility to their inferences, but there's also significant harms. And I think we need to reconcile all these together. This data just shows a forest plot showing a very modest improvement in eczema severity and a standardized mean difference of 0.2. shown there on the bottom in the forest plot of pooling all the studies. Now, because of the balance of benefits and harms, we made a conditional recommendation against the use of elimination diets. Most patients would value avoiding uncertain harms, such as the higher chance of developing a food allergy, compared to the uncertain small benefits to improvements in atopic dermatitis control. And it was driven really by shared decision making that we think patients and clinicians should engage in and discuss. And so, beyond just food allergens, we also looked at air allergens. When it comes to air allergens, there's quite a number of studies, 23 randomized trials, about 2,000 patients studying the use of subcutaneous immunotherapy and sublingual immunotherapy for atopic dermatitis. There were improvements to eczema severity, I'll show you next, quality of life, but there also are usual adverse reactions with both skit and slit. So this is a forest plot showing the available randomized trials that compared slit in the top half, skit on the bottom half, showing similar effects for both, and about a 1.5 times increase in the chance to improve 50% from baseline. The main allergen that was desensitized against was house dust mite, but there were some studies that included pollens or animal dander. Now, because of this, we suggested to use allergen immunotherapy in those with more moderate severe disease, especially those refractory or intolerant to use mid-potency topical treatments. And this should be a conditional recommendation. In other words, there's a shared decision-making to take place and many factors to consider. We describe those again in the guideline and the e-appendix. But in those with mild disease, in general, we suggested against using this therapy, although one should consider the patient's values and preferences in the moment as well as their comorbidities. So factors to consider would be those such as allergic comorbidities that would be likely responsive to AIT. Maybe your patient has severe rhinitis or moderate to severe asthma that would improve with allergen immunotherapy, in addition to atopic dermatitis. So they might, if they're on average more on the milder side of moderate, that they might still go for it, even though the recommendation may be quite weak alone to use it for the atopic dermatitis. Or maybe the patient has mild, moderate, or severe atopic dermatitis, but as usual, they find both skit and slit inconvenient, or their age they prefer not to use it, or they have significant travel commitments that would prevent them from using it. So there are many considerations that you'll have to go through to make sure this therapy is the right for the patient in front of you. The adverse effects are common, and as you know, local and site reactions in the majority for skit, or pharyngeal reactions for about 10%, 13% of individuals with slit, usually mild, and systemic reactions are about 10% for skit. There's some thought about a potential to flare atopic dermatitis. However, there's no robust data to show that that is very frequent in those going through skit. Rare for having a systemic reaction with slit. Okay, moving on to additional adjunct therapies before we get on to systemic therapies. Dilute bleach baths for severe, moderate severe atopic dermatitis. We showed that it could reduce clinician-reported severity with moderate certainty evidence by about 10%, will improve by about 50%. In other words, it would reduce their severity on average by about 30%, 20%, and with little to no overall low certainty evidence for the other outcomes. So what this means is that for those with moderate severe disease, we suggest adding dilute bleach bath bathing as a conditional recommendation. Again, that has to fit into their routine. They have to have access to a bathtub. They need clear written instructions, which again, the e-appendix provides implementation tools for that, and patient values and preferences. Sometimes patients have very extensive open skin, and those cracks and fissures actually make it intolerable. But we also heard from our patient partners that a number of them actually preferred having that sensation because it soothed and was replacing the itch. So it does really have to depend on your patient. You have to make that individual decision. For those with mild disease, they're less likely to benefit from an improvement with bleach baths, and so we made a conditional recommendation against it. Systemic treatments. Now, this has really been revolutionized in the past few years with biologics and other small molecule inhibitors beyond those that are conventional treatments. Our network meta-analysis was the first to include everything, including phototherapy, over 140 randomized trials, 20,000 participants, almost 30,000, and it was in JACI. So this is a summary findings table. I won't go through it in full detail, but I'll focus on some key ones here. You can see here dupilumab in the third row down was the key intervention that was able to improve multiple patient-reported outcomes and very closely followed by tralokinumab with small differences between the two, but dupilumab seemed to have potential for a slight edge. Same thing with lebrikizumab, very close as well. And so lebrikizumab is coming down the line. As you know, dupilumab inhibits both 4 and 13, IL-4 and IL-13. Lebrikizumab, tralokinumab inhibit only IL-13. So lebrikizumab is not yet available, and so the recommendations made strong recommendations for both dupilumab and tralokinumab in those that are refractory, intolerant to mid to high potency topical treatments. There's multiple implementation tools in the e-appendix, and the dosing varies by age and weight. Most patients will require topical therapies in addition to these systemic therapies, so please don't forget to continue to encourage those common fundamentals of skincare. Side effects are common with conjunctivitis, and it's thought to be higher the more severe the disease is. So look out for the need to use lubricant eye drops, warm compresses, and consider ophthalmology referral for severe conjunctivitis if needed. Now, for the JAK inhibitors, there are a series of JAK inhibitors. Some are approved elsewhere in the world and not in the United States. So that would be, for example, baricitinib for atopic dermatitis, mainly approved in Europe and Japan, but not here in the US. But abrocitinib and upadacitinib are available here in the States. You can see here from the color gradients that on average, high-dose upadacitinib rose to the top of most effective therapy overall. But you can also see on the right-hand side, all of these drugs had a dose-dependent increase in adverse effects. Most of these adverse effects are on the milder side, but still can be bothersome, such as acne, gastrointestinal distress, herpes simplex infection is also increased, and there are a number of other key considerations that will bring you to on top of that box warning that is class-wide effect right now. So as a consequence of the JAK inhibitors, we say consider if refractory not only to mid to high potency topical treatment, also a systemic treatment inclusive of a biologic recommended earlier on. There are many conditions to consider: comorbidities, risk factors, and God's preferences, and including exceptional circumstances. About these, we conditionally recommend the use of abrocitinib and upadacitinib among those that where it's accessible. We recommend it against baricitinib once a day. And for all the conventional therapies, we made a conditional recommendation against, because these are really specialized use in special case scenarios that require expert assessment. We made a conditional in favor for cyclosporin, given its better efficacy and safety profile, but it is a short-term therapy that needs to be transitioned to get off of to a better treatment plan. And the systemic steroids, we made conditional recommendation against, because it often leads to rebound flares and a very bad vicious cycle. And so there needs to be a transition plan off of systemic steroids as well. So the JAK inhibitors, they have slightly different targets of specificity. They all require laboratory monitoring and are generally approved for age 12 and above. There are many infections and adverse effects to look out for, as well as baseline blood work that needs to be done and considerations, and their drug-drug potential interactions. Baricitinib, as mentioned, not available for atopic dermatitis in the US. The box warning still applies to the JAK inhibitors until there's better, robust long-term safety data. There's existing some reassuring data, but still overall low certainty evidence, and we're working towards systematically appraising that. With the JAK inhibitors, there were no cancers, deaths in those studied in the atopic dermatitis studies, but there are also short-term studies. We're talking mainly 16-week studies, very few up to 52 weeks, some observational data now longer, but still emerging information. The oral surveillance study, as mentioned, 40-month multi-year study, 4,000 participants, but they had rheumatoid arthritis, and they were exposed to other drugs. But they found an increase in very serious adverse effects. So again, lowest certainty evidence for harm as a class-wide effect of these JAK inhibitors, and therefore we have to have this shared decision-making approach with our patients. Baseline screening, review full prescribing info, clarify pregnancy plans, age-appropriate cancer screening, herpes zoster vaccination, screen for the risk factors. I'll show you a table on the next slide, and then blood work, including TB screening, and consider HIV, Hep C, and then repeat labs initially in 4 weeks, and then potentially every 3 months as needed. Conditions that might favor against JAK inhibitor use: a history of or strong risk factors for cancer, serious infection, VTE or cardiovascular disease, severe renal or liver disease, plans for pregnancy or breastfeeding, elderly patients, which you might consider a lower dose, but also potentially lower efficacy, and then patients with a low tolerance for the rare risk of these adverse effects. Complete all the vaccinations beforehand before starting treatment. These are some of those common risk factors for cancer, VTE, arterial thromboembolism, and serious infection. They're detailed in the guideline, and I'll direct you to those. So for cyclosporin, this is also for those refractory to other therapies. We suggest using this conditional in favor of it, and that shared decision making should determine whether you start at a high dose, such as 5 milligrams per kilogram, or a low dose, 3 milligrams per kilogram. This can rapidly improve the eczema, but beyond a year, then you really need to think about the increasing chance for malignancy with the therapy. In addition, there's the more common side effect of hypertension, renal disease with it, beyond some other common but bothersome side effects such as hypertrichosis, gum hypertrophy. And so you need to discuss with your patients where their valence impairments lie and what their tolerance for risk is. Monitoring blood pressure and kidney function is essential, on top of other routine clinical monitoring for this therapy. And rapid discontinuation often leads to rebound. For narrowband UVB treatment, this is difficult to access, and so but effective, and so we made a conditional recommendation in favor of it. Again, the shared decision-making approach. And some things that might be able to treat more than one disease, such as psoriasis, vitiligo, might favor you more towards using it. But conversely, if people have photosensitive dermatoses, they may be less likely to use it, or a history of skin cancer. Systemic steroids, as mentioned, they can improve atopic dermatitis severity, but the benefits are usually short-lived and lead to a significant rebound effect upon discontinuation. The adverse effects of being on systemic steroids include weight gain, insomnia, adrenal insufficiency, growth impairments, and there's a very large association with many different harms, as you're all well aware of, ranging from infection, VTE, fracture, with recurrent use. And so really we need to stop the cycle of recurrent systemic steroids for uncontrolled AD and transition them to a more effective and safe long-term plan. So in full, the guidelines are associated with many infographics. They're associated with implementation tools. They start with a good practice statement for correct diagnosis, education, trigger avoidance, medication use, and skincare. TCIs are safe and effective to use, do not increase cancer. The comparative effectiveness and safety summary for shared decision-making can be used at point of care. You can even bring up these tables to discuss with the patient. You have flexibility to use twice versus once a day for use. And we recommend for using proactive therapy for relapsing AD. We recommend against elimination diets. Engage your patients rather than what they're used to and may have their guard up on about being ignored. And so balance and communicate with them those harms and burdens and limited benefit. Consider allergen immunotherapy in those moderate severe patients, especially those with seasonal flares or clear flaring around air allergens that are refractory to topical treatments or multimorbid mild disease. Consider bleach baths in those large severe patients who view the efforts of bleach baths worthy of the potential small improvements, and against those in the mild. And then there are many systemic treatment options, starting with dupilumab and tralokinumab, and likely in the future things like lebrikizumab and others that will become one of the first go-tos after refractory to topicals. And then after that is when the most common scenarios will be for considering other small molecule inhibitors that right now have an uncertainty long-term safety profile, but emerging reassuring evidence. The appendix contains a lot of implementation tools for practical issues that can be used as a discussion or even used in advance. So I encourage you to use those, print them out, they can be posters, all sorts of tools to implement. And with that, I'd have to thank a massive team to bring these guidelines to you. I'd like to very much appreciate COLA for the invitation to share these updated guidelines with you. And with that, thank you for your attention and happy to take any questions.